Hello guys, I welcome all of you to today's Pharmcast, and as you know, as every day I do, today also I'll be discussing 5 drugs of choice and one question or a concern that was asked by a student. And it's a valid question, considering that the time of revision is knocking on the doors, right? And the question is how to plan revision with respect to the weaker and stronger subjects of a person, right? So I'll discuss guys this part at last, how to plan a revision considering which subject you are weak in and strong in. So I'll discuss at last. Let us straight away begin with our drugs of choice that we have to cover today, 5 of them. First of all, colorectal cancer. Guys, colorectal cancer, the drug of choice is, think, what is the drug of choice? It has been asked a couple of times. Colorectal cancer, the drug of choice is 5-fluorouracil. But remember, we use regimens. Single best drug of choice, if they ask you 5-fluorouracil will be your answer. But if they ask you regimen, what we do, we combine 5-fluorouracil with folinic acid, which is also known as leucovorin, and that is further combined with either oxaliplatin or irinotecan, right? So this gives us regimens like Folfox, Folfiri, and we can combine all 3 of them, then that regimen is called as Folfirinox. So you can combine 5-fluorouracil with folinic acid with either oxaliplatin or irinotecan, or you can combine both oxaliplatin and irinotecan. So remember guys, colorectal cancer, drug of choice is 5-fluorouracil. Treatment of choice, these are regimens called as Folfox, Folfiri or Folfirinox. Moving on to our second disorder that we have to cover today, that is congenital megacolon, or as you know, it is also known as Hirschsprung's disease, which is caused by absence of the ganglionic cells in the rectum and some part of the sigmoid colon. The other part can also be involved. Now, why am I telling you this? Because I want you to understand why we have a particular drug that is used for treatment. See, when there are no ganglions, right, in your rectum and sigmoid colon, then what happens? There is no release of acetylcholine. That means M3 receptors are not being stimulated, and that is why the rectum and sigmoid colon, they do not contract, which means what, for treatment I have to give a drug that stimulates M3 receptor. So which is the cholinergic drugs? Which one is the cholinergic drug that is preferred for stimulation of M3 receptor in your GIT, bladder? Which drug? Think, you must have studied about it. It is beta-nicol guys, beta-nicol. Beta-nicol is preferred for stimulation of M3 receptors in bladder and GIT. That is why it is the drug of choice for congenital megacolon or Hirschsprung's disease. Now coming to the third one guys, COPD, chronic obstructive pulmonary disease. Think, what could be the drug of choice? See here, the drug of choice are long-acting anticholinergics, right? Why anticholinergics are the drug of choice in COPD? Because see guys, what is the cause of bronchoconstriction in COPD? The cause is progressive inflammation that causes sclerosis of the bronchi, and that causes bronchoconstriction. But there is one reversible component of bronchoconstriction that is present in COPD, and that is exaggerated cholinergic effect is seen due to inflammation. That is the only reversible component in fact. So to reverse it, we give anticholinergic, and that is why they are the drug of choice. Now remember, the preferred drug in COPD are long-acting anticholinergics by inhalational route, and we have 3 of them: tiotropium, umeclidinum, umeclidinum, and revefenacin, revefenacin. These are 3 drugs preferred, but the maximum experience we have is with tiotropium. That is why if they ask you single best drug of choice for COPD, it is inhalational tiotropium. Now I'll ask you one thing guys, think, what could be the most common side effect of inhalational anticholinergics? Think and you'll get the answer. Inhalational means their maximal effect, right, would be on the oral cavity as well. So what can they cause, anticholinergics in oral cavity? The answer is dry mouth. So dry mouth is the most common side effect of inhalational anticholinergics. Now moving on to the fourth disorder for today guys, cough. See, cough, for which we use antitussives, and remember, the drug of choice depends upon the severity of cough. So if it's a cough which is mild to moderate cough, then our preferred one is codeine. So opioids are overall the preferred classes of drugs for cough. Whereas if it is a case of severe cough, for example in bronchial cancer, then we use more potent opioids like morphine or methadone. Now, however, whenever you use codeine in older patients as an antitussive, you need to keep one thing in mind, that is constipation. Older patients are prone to constipation, and codeine also causes constipation. So that is something you have to keep in mind, and you have to ask the patients, elderly patients, if they have severe constipation, they can go for laxatives, right? Finally, guys, coming to the last disorder for today, and that is Crohn's disease. See, in Crohn's disease, treatment can be divided into two parts: induction and maintenance. Guys, for induction, if it is a mild case of Crohn's disease, induction, we go for steroids, and the preferred steroid is budesonide. Oral budesonide is preferred. Whereas for induction of moderate to severe cases, that is wherever there is fistulas are present, in that case we go for TNF alpha inhibitors like infliximab. Whereas if I talk about maintenance, then for maintenance, guys, the drug of choice are anti-TNF drugs like infliximab. They are the universal drug of choice for maintenance. So sometimes they ask you, there is a patient of Crohn's disease who already has a fistula, which drug would be preferred? And obviously your answer is infliximab. So guys, this is what we have to discuss today in the section of drug of choice. Now I'll come down to the last part where we discuss one of your queries which you ask. And guys, I would like to apologize if I'm not able to address each and every one of your queries, because there are a lot of them, but I select one of the most important one and I try to address in each of these Pharmcasts. So for today, the question is how to plan revision with respect to one's strong or weak subject. So it's a very good question, guys, and I'll tell you something which I did during my preparation. And whatever, guys, I'm gonna tell you now is to increase your efficacy in revision. You are the same person, right? You have the same IQ level, you have the same notes, but how to increase more efficacy out of these small constants? So we'll work on the variable. And what is that variable? How to plan the revision. First point, guys, write it down. Never go for bolus revision of a subject, which means what? Let us say, for example, pharmacology. I have dedicated 10 days, 10 hours a day, 100 hours revision. I should not be revising pharmacology at a trot in these 10 days. Rather, I have to break it down. Otherwise, you'll get bored and your efficacy won't be that much. So break it down. Let us say one day 10 hours I have to study. So I'll study one day only 5 hours or 4 hours of pharmacology. And which I was supposed to study in 10 days, I'll break it down into 20 days. So 20 days, 5 hours, the output number of hours is still 100, but I've broken it down into smaller components, right? So coming to the second point, which stems from our first point, that is, what about my other half of the day? How am I gonna fill it up? Now see, which means what I'm telling you is minimum 2 subjects should be revised each day. And how to combine 2 subjects? So you need to make pairing of subjects. How? See, guys, you need to select one subject where you are strong in and another subject where you are weak in, right? So I've selected those subjects, and let us say I need to revise 5 hours of strong subject, 5 hours of weak subject. Now let us try to plan your day. How will plan your day, guys? I'll begin the day with which subject? The one you are strong in or the one you are weak in? Guys, see, remember here, you have to begin the day with the subject which you are weaker in, because when the day is just beginning, you are fresh, you are raring to go, right? And at that time, it would be more productive to hit the weaker subject hard. But on the second half of the day, when you have studied or devoted a lot of time to your weaker subject and you are exhausted and you don't feel like studying, is it a good idea to go for another weak subject? Obviously no, right? So I'll rather go for a subject which I'm very strong in, so that my interest is maintained and I can get a fairly adequate amount of output. So guys, this is how you need to plan your days, keeping in mind, so that you can increase the efficacy of your revision, guys. So apart from this, in between these 2 subjects, every day you can throw 1 hour of MCQ practice, right, in between these 2, so that you have some kind of variability in your preparation. So guys, that's an effective way of planning revision, guys. Remember, you are the same person, right? You have the same IQ, you have the same notes, all of you there, you have been taught by the same teachers. But the variable here is how you do things, right? How you plan your revision, and based upon that, a lot of things will depend. The outcome will depend, guys. So that's all for today, guys, in this Pharmcast section. And if you have any particular concern, doubt you want me to discuss in my Pharmcast, Do let me know in the comment box. That's all for today, guys. Take care. Bye bye. This was Dr. Ranjan with you.